Morning, everyone. Welcome to the 14th annual McKusick lecture. I'm Jeff Sanders, the president of Maine Medical Center, and it's an honor to be here with you. This is a hybrid event, so we have a number of individuals joining us hybrid as well. What I want to do is talk about a little bit about the program. We've got some of the founders of the program here with us today as well, Dr. Peter Bates and Dr. Mike Roy, as well as others who are joining us hybrid. So I want to talk a little bit about the program, what we wanted to do when we started this program back in 2009, and where we are today. And we're honored to have Dr. Helen Boucher with us, the dean down at Tufts, which has just been an amazing partner for the past 14 years. So thank you for being here, and I look forward to hearing your lecture. So when we started the program back in 2009, we wanted to do a couple of things. Well, obviously, we wanted to bring allopathic medical education to residents of Maine and beyond. We wanted to provide financial support to bring down the cost of education for students from Maine and others as well. What I'm going to show in the next few slides are individuals, corporations, foundations in the state of Maine who have provided tremendous financial support for this program. To date, we've been able to provide $23 million in scholarship support to students going through this program. What that looks like every year is 20 scholarships per class for a total of $2 million. I met a couple of colleagues here whose children are in the program, and I share that I'm a Maine kid. And so when we think about what we're trying to do to help education in Maine and to help with the professional workforce of physicians is tremendous. And I'm going to share a little bit of that as I finish up my slides as well. But these are those who have contributed to this program and will going forward. I want to stop and acknowledge them with a round of applause. Talk about our students, this class included. The students come from every corner of the state of Maine. We should be very proud of that. They also come from around the United States. We should be very proud of that too. What we've been able to create with Tufts, the Maine Track program, is a program that students want to come to. Thank you for selecting the Maine Track program, and I look forward to actually seeing this class around campus over the next 4 years. One of the things we also wanted to focus on, as I mentioned, is the physician workforce. Of the students who have finished their training, who have graduated from this program, half of them are working back in Maine. Now, it's great that some of them are working around the country, but the fact that half of them are working in Maine, not all of them in Cumberland County, you can see throughout the state of Maine, we have 2 up in Aroostook County. It's important. I'm going to show a slide in a minute about how we have partnerships throughout the state of Maine through clerkship programs, through the LIC third-year program that really has connected this program to our community, our broader community, and I think has created a pipeline for those finishing training who want to come back and practice throughout the state of Maine. So our educational partners are remarkable. From the beginning of this program, we've had partners throughout the state of Maine in every corner of the state who have helped with orientation, who have helped with clerkship programs, and who have helped with students who choose through the LIC program during their 3rd year. It's been a remarkable opportunity, I believe, for students. It's been a remarkable opportunity for us to connect with the state of Maine and really understand what it's like to practice medicine outside of a community like Portland in a more rural setting. Also want to talk about our students, and this class will be no exception. Our students have done incredible work. They've been recognized through the work that they've done with their peers down in Boston through recognitions like the one that I'm sharing here. I also want to recognize our faculty. This program would not be possible if we did not have the dedicated faculty we have down in Boston and the remarkable faculty we have up here in Portland and throughout our state. Every year, our students recommend faculty for recognition. So the couple of slides that I'll share are the faculty who were recommended last year. And you will get to meet them if you haven't already met some of them. And I want to take a minute to congratulate that faculty and thank them for the work that they've done. And lastly, I want to thank the McKusick family. I want to say a word or two about Victor McKusick. He spent his career down at Johns Hopkins, at the university, and at the hospital. Dr. McKusick, along with peers, were the pioneers for what we know about medical genetics today. We can thank him and his peers for the work they did 40 to 50 years ago, the groundbreaking work that we now have the benefit of building upon. The lecture here today starts off the 4 years that you'll enjoy here in Portland and down in Boston. And I think it's an honor that we have Dr. McKusick to thank for his work and for lending his name to this lecture. I also want to acknowledge that the McKusick family recently lost a dear family member, Nancy Green McKusick, who was the sister-in-law of Dr. McKusick, passed away this past year. I want to acknowledge her and her passing and their family. I also want to acknowledge that Dr. McKusick's son, Reverend Victor McKusick, and his wife, Lori, are joining us in the hybrid today. So thank you for joining us, and thank you for carrying on the family tradition. Now it's my privilege to introduce Dr. Linda Chaudhry, who's the Vice President for Medical Education, the Robert Bingu Chair of Medical Education at Maine Medical Center. Thank you.
Thank you, Jeff. I am thrilled to be here, and I hope you all recognize I was sitting there listening and realized that the president of the medical center knows more about the Maine track than I do at this point, having been here only a year. And I just want to thank you, Jeff, for your continued commitment that you can see is so true and genuine toward our learners across the continuum. So I want to give you a round of applause and thank you for your support. So I was asked to say a few words before we move into the lecture. And I wanted to say first that I'm really honored to be here today with you as students. And I know there are family and friends both here and virtually, as well as many of our faculty and donors. There's a whole community around you. I joined Maine Medical Center and Maine Health almost 1 year ago, August 1st, and I feel like I've been here forever. In your 24 hours here, I've heard many of you say this has just been a welcoming and warm place. And I would say what you experienced in 24 hours, you will experience for the rest of your time here. It is truly a remarkable place, and I am grateful to be here, and I know you will be as well. We have some things in common. This is my first McKusick lecture. This is your first McKusick lecture. And we're actually in person. So this is great. Last year, I tried to welcome the class when I got here, and I was on Zoom and garbled, and it didn't work so well. So I'm really happy to be in person, as we all are again. So since I've only been here a year, I thought I would give you a couple of things to look forward to from some of the things I've learned. I know many of you are from Maine, but I learned that I'm actually from away. Apparently, that's a thing. So one of the primary things I've learned is truly how welcoming and wonderful the people of Maine are, not just at Maine Med Center, but everywhere. I have found that Mainers know how to work hard, but they actually really know how to balance their lives outside of work. And that's going to be so critical for your career. So learn from the best here in Maine. Maine Medical Center, Maine Health is deeply, deeply committed to the health and well-being of the people of Maine. And that is part of what drew me here. Listening to Jeff, seeing our partners across the state, we are part of the future of the state of Maine for people's healthcare and for the workforce. And that's what drew me here, because it is a true commitment. The Department of Medical Education here at Maine Med Center, the staff and the faculty, as you've all already experienced, are very committed to you as students, to our residents, to our faculty, and to one another. The Tufts University School of Medicine faculty, staff, and students are the best colleagues we could ask for and collaborators, and I'm honored to be on their faculty. You already heard the Maine track is an amazing and unique program, and I know I spoke with some of you earlier today who said it was your first choice and you knew this is where you wanted to be, and I think you know how amazing it is, but I think you will learn more as you go through here. You are lucky, as am I. You will have experiences and homes both in Boston, at Tufts, and up here in Maine. And you will have amazing people to help you all along the way. And I'm honored to welcome you to your Maine home. So welcome. The next thing I wanted to say is because this is our first lecture together, Dr. Sawyer, who you met yesterday, apparently usually would give you a homework assignment. After this, I will not. I'm not that detailed and I'm a big picture person. So what I thought I would do today is tell you a few things that you didn't hear about Dr. McKusick that I learned, just some interesting facts. He had an identical twin. He grew up on a dairy farm in Parkman, Maine. And this one was really important to me, that it was his personal experience of having an infectious disease that made him interested in pursuing medicine. He was admitted to Johns Hopkins University School of Medicine without receiving a bachelor's degree, but he had completed 6 semesters at Tufts undergraduate, which was new to me, maybe not new to others in the audience. And the reason he was admitted without a bachelor's because the requirements were waived during World War II. So he was one of very few people who were able to do that. He also finished medical school in 3 years, I read, which that there's a whole dialogue about that nationally right now. So we all come back around with our thoughts and ideas. He was a cardiologist, but he changed course and as you know, became the father of medical genetics after an encounter with a patient with Marfan syndrome. He founded a course on medical and experimental mammalian genetics at the Jackson Laboratory in Bar Harbor in 1960 and continued to attend those lectures until his death in 2008. So his legacy is broad and amazing, and we're lucky to have him from our state. The thing, though, that was most impactful for me learning about his background and that was inspiring, that I hope you will find inspiring as well, is that he made his mark in medicine by following his questions and his wish to seek answers and his passion and his interests. And Dr. Boucher and I were just talking earlier about how our paths are not linear. Your path in medicine will not be linear. Your training may feel linear, but your path will not be linear. So stay open to ideas, stay open to opportunities because you just don't know what's going to come down the pike. And I think his story helped to inspire me as I'm thinking about that. So with that, let me introduce you now and welcome our distinguished lecturer, Dr. Helen Boucher, who you all already know as Dean Boucher. Dr. Boucher is the Dean ad interim of Tufts University School of Medicine and the Chief Academic Officer of Tufts Medicine Health System. She's professor of medicine and an international expert in infectious disease. And she's the founding co-director of the Stuart B. Levy Center for Integrated Management and Antimicrobial Resistance. Does that have an acronym? Because that is really a hard one. Prior to becoming dean, she was the chief of the Division of Geographic Medicine and Infectious Disease. Her focus has been not just research, which is a huge part, but education and policy around drug-resistant medical infections, in particular in immunocompromised patients. In addition to her clinical expertise and her research, she's a career educator. And this is really important because her commitment to all of you as learners is so authentic and clear at every turn. And I'm just so lucky to be working with her. I'm fortunate to have gotten to know her over this past year, and I have just been so impressed with her ability to really give every group of the Tufts University School of Medicine community, whether it's faculty, students, residents, her support and full attention. And I know many of you already interacted with her and see how approachable she is and such a wonderful person. So with that, I just want to say, given that Dr. McKusick's interest in medicine initiated by an infection, that was resistant to medicine, it's only fitting that Dr. Boucher give today's lecture, which we are going to go ahead with now. Only now I'm going to figure out the technological part. So thank you and welcome, Dr. Boucher. All right. I did it. Thank you.
Thank you so much, Linda. Good morning, everybody. It's a real honor to be here. And for the students I met, it was really nice to meet you. And for those I didn't, I hope I'll meet you during lunch. And I'll just ask you what I ask all the students. If you see me around in Boston, please say hello. Remind me who you are. I really want to get to know you and look forward to working with you over the next few years. As I drove up this morning, beautiful, beautiful morning to drive up to Maine, I want to share with you that I'm going to become more of a Maine person. My baby, my youngest, is going to start college at Colby this year. So I'll be up here more often. Yeah. And as Linda mentioned, we have a very special place in our hearts at Tufts for the Maine track. Really grateful to Peter Bates for your leadership and friendship while I've had the opportunity to be in this role. And I'm really happy that every great disease is an infectious disease. And we're going to talk about the problem of antibiotic resistance for just a few minutes this morning. So my disclosures are shown here. I'm involved in a book about antibiotics, and I have the privilege of serving on the Presidential Advisory Committee for combating the problem of antibiotic resistance, which I hope I'll convince you is a big problem for all of us, and one that's going to be with you for your careers. And I hope you'll take some interest in trying to be part of the solution. So the title of my talk was A Silent Pandemic, and that's kind of an ambitious word to use as we're still dealing with the pandemic of COVID. But I will posit that antibiotic resistance is a pandemic, and it's been one for years, and it's one that's really upon us. I love this quote from Dame Sally Davies. She's the face of antimicrobial resistance in Europe. She's now a UK special envoy for this problem. And she said, COVID is a lobster dropped into boiling water, kind of a Maine thing, making a lot of noise as it expires, whereas AMR, or antimicrobial resistance, is a lobster put into cold water, heating up slowly, not making any noise. So I thought I'd start with a couple of cases because I'm a clinician and I always think it comes back to our patients. So this is a case of a young lady, otherwise healthy young lady who has a history of injecting drugs. She had 2 prior episodes of endocarditis, or heart valve infection, related to opioid use. And for the first one, she had to have a repair of her tricuspid valve. The second one was caused by methicillin-resistant staph, or MRSA. It involved that valve that had been repaired. And her treatment was complicated. She got kidney failure from vancomycin, a very common toxicity of that drug, had to be in the hospital a long time. And then she got a sternal wound infection, so related to the surgery that she had from that same bug. She comes back, the sternal wound got worse, it extended into her chest, into the mediastinum, and oh, by the way, she's 22 weeks pregnant. So she was with us for a long time, multiple surgeries, multiple courses of antibiotics, in and out of the intensive care unit. She delivered a healthy term baby in the ICU, so somewhat of a spectacular thing, and her problems unfortunately continued. So this is a lady who's living from a very young age with a resistant infection that may cause her ultimate demise. And the message here is that persons who inject drugs are 16 times more likely to develop MRSA infections. So huge problem. I know it's a problem in the Maine community and in all of our communities. So contrast that to a 47-year-old lady, school teacher, who comes in with pain, urinating, and some lower abdominal pain, and she's given ciprofloxacin, kind of standard therapy. 2 days later, she comes back. She's having chills, back pain, nausea. Now she has a fever and she has tenderness over her kidney, and her urine looks infected. She has elevated white blood cell count. So now she has a kidney infection, pyelonephritis. But she was otherwise healthy, so she looked okay to go home. She got 1 dose of intravenous ceftriaxone, again, kind of standard drug, and then oral trimethoprim sulfa. So she gets worse despite this, and comes back with high fever, low blood pressure, shock, and has to come in, get resuscitated, vomiting, really sick now. And despite those antibiotics that I just reviewed, her urine culture grows a bacteria called Klebsiella in a significant quantity, and it's resistant to multiple antibiotics as shown here, and it's what's called an extended spectrum beta-lactamase producer, ESBL. So we have no pills for that. So she's admitted to the hospital for intravenous antibiotics for 2 weeks. So even if she's well enough, she will go home with an IV to finish those 2 weeks. So no work, no school, big impact in an otherwise healthy lady. This is not somebody that I usually take care of with an organ transplant, this healthy lady. So I think that these cases show us that the problem of antimicrobial resistance is here. It can affect us, our children, Katie Kirk's daughter. I mean, it's in the news all the time. And these infections threaten modern medicine. We'll talk about that. Our patients need more treatments. We need pills for like that lady school teacher, right? And that's what I've spent a lot of my career advocating for is how to make this better. And we as physicians, as you're going to learn very soon, we have to make decisions with the data we have, which is often less than the data we want. So that's a whole field of study, how we develop medicines, how we develop the data to make these decisions that you're going to learn, but we often have to extrapolate. So as you learn about the thought process and decision-making, it's really, really important to get that because it's something you're going to need your whole career. People don't always walk in with a textbook-like infection, and Dr. McKusick learned that in his career as well. So this is just some of the lay press around this problem that you've probably seen over the years. Since even you were children, I started getting active in this field. Well, really 30 years ago, I did this in the lab, but more like 15 to 20 years ago, I started getting involved in the advocacy around this. And a lot of it stemmed from reports like this. This is the famous O'Neill report that came out in 2016. Lord Jim O'Neill is an economist, believe it or not, in England, who got interested in this problem because he thought nobody was counting it right. Nobody was getting it right. And so they did really an economic analysis that showed that if we do nothing by the year 2050, as many as 10 million people could die every year from antibiotic-resistant infections. Scary number. Some people said it was too much hype, but it got some attention. More recently, we had a paper that came out in the Lancet this year, looking at 2019 data. And interesting, it's Chris Murray and colleagues, and you might recognize his name. He's one of the big COVID modelers. So they got interested in this problem even during COVID. And they said in 2019, 4.95 million people died with antibiotic-resistant infections. And of those, at least 1.27 million deaths were directly caused by the antibiotic-resistant infection. So this is the same concept we have as with and from COVID, we have with and from antibiotic resistance. And based on these data, resistant infections or superbugs, as they're sometimes called, kill more people than malaria or AIDS around the world. So why should we care? Well, we need antibiotics, right? Every person who we do surgery on, right? The most common surgery in America is joint replacement, hips and knees. We have to have antibiotics to cover those patients so they can have safe surgery. Organ transplant, chemotherapy for cancer. We have to be able to support these people, and resistant antibiotics or resistant infections are limiting our ability to give these therapies. So how did it get so bad, right? Science, in nature, bacteria become resistant over time. So that'll happen no matter what we do. But what we have done, we people have overused antibiotics, and we've overused them in people, animals, and the environment. It's a One Health problem. We'll talk a little bit about that. We really overdid it in COVID. In the beginning of COVID, when people came to the hospital, we gave them antibiotics because they had pneumonia. And we were worried initially that COVID was like the flu and people would get what's called a secondary bacterial infection, where the bacteria would come in behind the damage from the virus. Turns out we were wrong about that, and we way overused the antibiotics. And this made the lay press. These are some papers from the New York Times and others. Just last week, a report came out from CDC further quantifying this and looking at the problem in America of antibiotic resistance up to 2019. News is not so, up to now, 2022. The news is not so good. It turns out that before COVID, we were making a little bit of progress with this in the hospital with things like preventing infections, washing our hands, doing procedures well, and other things. But once COVID came, we kind of had a backslide. So 15% worse overall. And then as you can see here, certain infections much, much worse. So work for us to do, and overuse of antibiotics is a big part of it. And it's not just overuse of antibiotics in the hospital. In fact, it may be more in the community. And for you all, you're going to be going up into rural practices, and you're going to see lots of different kinds of practice in your career. And this is something that I think is fascinating. So this is data from Lori Hicks at the CDC, and she's a leader in looking at antibiotic use. And she looked at a very simple question. So prescribing antibiotics by geography. So what happens across different states? And as you can see in the map of the United States, the colors are different, and the darker colors are more antibiotic prescriptions. So what's going on, right? The lowest state is Alaska, 462 per 1,000. The highest state, West Virginia, 1,197 per 100,000 population. Are the people that different? Are the infections that different? Or are the prescribers that different? So we don't know all the answers, but I would posit that the people aren't that different. So lots of difference in prescribing practice here. This is not just a US problem, it's a global problem. And this is a look from probably the leading group called the CDDEP. If you're interested, their website is at the bottom. And they looked at treatment trends around the world. And one of the there's two big differences I'll try to highlight around the world. One is antibiotics are available over the counter in many places. And this is a person getting antibiotics at a pharmacy in India, where you can just walk in and get whatever antibiotic. The other problem or challenge in low and middle income countries is that there isn't good access to antibiotics. So we have babies dying of infection and not enough doctors to treat them or access to those doctors. So as we think about solutions, we have to think about it in places like ours, where we have overprescription, and places like low and middle income countries where they don't have access. And that's another challenge. Then there's animals. So antibiotics are used in great quantity in food animals and other animals, including so-called companion animals. And at Tufts, our vet school is a world leader in companion animal vet stuff. So dogs and cats. And it turns out that they get a lot of antibiotics too, but over 60,000 tons of antibiotics are used in animals every year. And they're used both to treat infections, sick animals, but also to prevent infections. And they used to be used for growth promotion. And in some countries, they still are. That is to make the chicken breast fatter, to make the cow fatter, so they'll have more meat. We now have at least 40 countries around the world that have policies to limit the use of antibiotics in livestock. And one of the things I've learned in doing this work with this One Health lens is that there's a huge difference between kinds of animals. So cows are different than pigs, are different than fish, which is very interesting. This gives you like some view of that. Each color of these stacked bars is a different species of animals. And just by a quick glance, look at the pink bars. That's for the pigs. Many, many more tons of antibiotics are used in pigs than in other animals. And then you can't really see well here, but the dotted lines at the top are fish. And the reason those lines are dotted is because that's the margin of error. We know so little about what's done with our fish in terms of antibiotic use. And just to give you some perspective, in Norway, they actually vaccinate the salmon to prevent antibiotic-resistant infections. We don't do that in America, but there are other ways to deal with this besides giving them antibiotics. And why do we care? Because people get sick, right? They get sick from food-related illness. This is an outbreak of salmonella. I just had a friend in the last 2 weeks get Campylobacter, sick as a dog for 5 days. So, getting sick from food is an issue. It's not as common in the North. I went to medical school in Texas. We had a lot more of it. But when it happens due to drug-resistant bacteria, it's even worse because it takes longer to identify and treat. So just coming back to the access problem, I didn't want to miss it. This is an issue in low and middle income countries where we still have unacceptably high mortality due to infections, and the access issue is a big priority for WHO. So hopefully you get the idea that this is a multi-pronged problem, so we need a multi-pronged solution. And this is just one diagram to show the variety of approaches that we need to take if we want to fix this, right? We want to prevent infections. If we can prevent an infection, that's much, much better than having to deal with one. We want to take good care of the few antibiotics that we have. That's called stewardship. And you're going to learn about that because your hospital has a stewardship program that's very good. Excellent faculty here in Maine and in Boston actually doing that work. Surveillance, we want to know what's causing the infection. We don't even always know that, believe it or not, in America in 2022. We need workers. We need infectious disease physicians, pharmacists, others. So I hope you'll think about infectious disease. We need lots of research and we need new medicines and vaccines. Most importantly, we have to know this is a problem. And that's really what I'm here to tell you about today. But I thought this was a great tweet. This tweet is from Mark Mendelson from South Africa, who's a leader in this area. And the date was October 8th of 2020, if you can remember back to then. He said, COVID, 1 million deaths in 10 months. AMR predicted 10 million deaths per year by 2050. We have yet to overcome the hurdle of the AMR pandemic. That was then, it's still true now. So why is that? Like, what are we doing wrong, right? You don't hear about this on TV every day. The Wellcome Trust did a great study, and the link is shown here if you want to learn more. They basically boiled it down to 5 things we have to do if we want to convince people this is a problem. We have to frame this problem as undermining medical therapy. You might not be able to get your heart transplant if I can't control that infection. Explain the fundamentals succinctly. Antibiotics are overused, they cause resistance. Emphasize that it can affect everyone, just like that healthy school teacher. Focus on the fact that it's a problem now, today, for everybody. and then encourage people to do something about it, right? All of us can do something about it. We can ask our doctor if we really need that antibiotic when he or she is prescribing it. So speaking of antibiotics, we need antibiotics to treat these infections when they come. And this chart shows what happened to the FDA approval of antibiotics over a period of years. And you can see that steep curve down. That's what got me and a lot of other people like me interested in this problem initially. We were seeing the bad bugs and less drugs. So we started a campaign called Bad Bugs, No Drugs. And from that, a lot of this work emerged starting back in like 2005, 2007. The reasons for this are many, and we'll talk about a few of them. But our ultimate kind of throwdown was to have 10 new drugs by the year 2020 to treat resistant bacteria. And we actually got there. We got 14 new drugs by 2019, as shown here. So that was kind of good news. We thought maybe that's a win, some progress. There's a lot more to the story, but I'm keeping it short for this audience. But there was some bad news. Nobody's buying. So it turned out that the companies making these drugs were all losing money. And in April of 2019, of the 5 companies, 4 of them had stocks under $5. One of their stocks was 17 cents, and that was like the day before they went bankrupt. And several of these companies ended up going bankrupt because no one was buying the new drugs. So we and many others kind of made a call to fix the pipeline and figure out how to get more antibiotics for our patients. The way to fix it is pretty complicated. So we looked at the problem in terms of getting people to try to discover new antibiotics. The big pharmaceutical companies got out of the business because there was no money in it. So that's called push, when you're pushing a drug towards FDA approval. And then also setting up a place for those drugs to be purchased when they're approved, that's called pull. So on the push side, a public-private partnership came to be called CARB-X that you might have heard about in the news, multi-million-dollar investment from the government, Wellcome Trust and others, and they've been very successful, over 50 projects that have been developed for drugs, diagnostics, and vaccines. On the pull side, a lot of things have been considered, tax breaks, extended patents, but the most kind of popular now is a so-called Netflix model, where a company would develop a drug for a resistant infection, and if they did that, they'd be promised a return of so many dollars, 1 or 2 billion maybe, over 10 years, if they used it to treat those resistant infections and they did it with good stewardship. So they made sure that the drug wasn't overused or oversold. So this is the US model is in legislation now called the Pasteur Act. It's in Congress in both houses. It's being very well supported, and we hope it'll come to pass. So when we get those new antibiotics, we have to steward them. And I mentioned that earlier. So there is a science of antibiotic stewardship, and that is choosing the right antibiotic at the right dose for the right patient for the right duration. And this is something you're going to learn about no matter what kind of medicine you go into. And it's really, really important. And the goal of this is to have the best outcome for our patients. It also brings the benefit of less resistance and often lower costs. So we at Tufts have had stewardship going for more than 15 years, really almost 20 years now. And it's been very successful, as you have here in Maine, in improving patient outcomes, decreasing antibiotic resistance, and actually decreasing safety errors with our patients. That's the other big place stewardship comes in. And the kinds of things the stewards do are stop antibiotics when they're not needed, switch IV to oral, really think about the dose appropriately, and all things you're going to learn about in the next few years. This is just one piece of data showing that good stewardship programs impact resistance. And that's really, really important. And the importance of this is that having resistant bacteria in your hospital is bad for the patient who's infected by the resistant bacteria, but for everybody else, right? For the person in the next bed who you or the other healthcare provider might inadvertently carry that resistant bacteria too. So a very different kind of focus as we think about it. And then finally, I want to leave you with a real emerging area of importance in the kind of addressing the problem of antibiotic resistance, and that is equity. So it is true that people from marginalized communities, and we talked about persons who inject drugs, but there are many others who are disproportionately affected by antibiotic-resistant infections. So this is a paper from our group, but there are others sort of making this point. So we have in our mission at Tufts University and Tufts University School of Medicine to become anti-racist, part of our work in antibiotic resistance is actually focused on addressing these disparities and inequities. So finally, I'm going to just leave you with, we need to prepare, right? One thing we know, we've learned from COVID, we have to be prepared. And I would submit to you, I hope I've convinced you that we need to prepare to be ready for antibiotic resistance. And you know that we have to think about this in a multi-pronged way with a One Health lens, thinking about humans, animals, and the environment. So with that, I will say thank you to all the people who I have the privilege to work with and to our patients and families who teach us so much, and wish you all the very best as you start out at Tufts. Thank you. So we have time for a couple questions, comments, feedback, compliments, as one of my friends used to say.
Could you tell us what stewardship looks like in that?
Yeah, it's a great question. So we've heard about antibiotics becoming resistant to things like hand sanitizers and other agents that we use. Fortunately, that's less frequent than we might be concerned about, but it's something that bears watching. And so our infection prevention colleagues look for this as they do their surveillance across the hospital and the health system. And I'm very excited that my friend Dan Diekema is coming to be the chair of ID, infectious disease here at Maine. He's a world expert in this area, so you're going to have a rock star among you very soon. Sure.
Like broad spectrum antibiotics can be phased out like this?
What a great question. Will broad spectrum antibiotics be phased out along with this? So we didn't get into this whole discussion, but it's a great point, right? Broad spectrum antibiotics will breed more resistance. So it's a bit of a complicated answer, right? So in clinical medicine, we often don't know what's going on with the patient when they present to us. So sometimes we need to start with broad spectrum antibiotics, but we want to keep that as short as we can and get to so-called narrow spectrum as soon as we can. Of that list that I showed you of the 14 drugs, most of them were in the more broad spectrum category. People have tried to develop narrow spectrum drugs, and we and others have worked on kind of pathways for how one might do that. The challenges are many, and one of them has to do with diagnostics. We have to know what's causing the infection to use a narrow spectrum agent. So we still have a lot of work to do in the area of developing diagnostic tests. There's a whole field of diagnostic stewardship as well. So it's really good to use narrow therapy when you can. It's just not always possible, but great question. Sure, hi.
Are there settings outside of, thank you. Are there settings outside of clinical settings that have been identified where individuals contract these kind of infections?
Good question. So are there settings outside of clinical settings, outside of hospitals? And yes, absolutely. So people contract antibiotic resistant infections in the community. And so if we look at the CDC data, there was a 2013 report and then a 2019 report. In the 2019 report, we saw that hospital-associated resistance went down a little bit, community-associated went up. So people were getting more of those like nasty urinary tract infections we talked about in the community. So those are people who have no intersection with healthcare at all. And skin infections due to MRSA, we see in the community all the time. So yes, it happens in the community as well. Great question.
Regarding physician accountability or accountability of those that are providing the drugs, is there, I guess, a mind to extrapolate sort of what we see with prescription monitoring program to almost like not penalize the providers, but track the volume of prescriptions and try to keep them in check through that means?
Yeah, great question. So keeping clinicians accountable. So part of stewardship has many different tools that we use. So one of the tools is called audit and feedback. So that's where, and this is done in our group of infectious disease doctors, where we're audited across a quarter, half a year, or a year. And then one way it's been done is it's shown de-identified. So we have 33 infectious disease physicians showing our use of drug A, B, and C. And let me tell you, it's not homogeneous, it's heterogeneous. So getting a message that you're one of the 5% greatest users of drug X has a behavior, can cause behavior change. So it is used, it's used by health systems. It's used by companies. It's used in different ways. I think the caution I would have is that it's really important to have the context for how those types of audits are used, because there are different kinds of patient groups and different scenarios, but it's a great tool. It's one of many tools, but it's a great tool. Great question. Sure.
Hi, I'm just curious about any efforts that are going towards sort of probiotic therapies for
Ah.
people after they've been treated with antibiotics, or if probiotics are being thought of as being used as like a preventative measure instead of just reacting with antibiotics.
Yeah. So what about probiotics? So I have to tell you a Tufts story, right? So one of the first probiotics, Lactobacillus GG, was discovered at Tufts by doctors Gorbach. And there's a ton of work on probiotics and their use. To boil it all down, I would say that we have limited evidence that probiotics have a big impact. That doesn't mean they don't. It means we don't have the evidence yet. So the whole science of the microbiome and how to alter it is really rapidly emerging. And one of the things I didn't get into, but these public-private partnerships doing incentives, they're funding both antibiotics and things like microbiome altering agents to see if we can figure it out. And there's all kinds of hypotheses, like taking such an agent could get rid of resistant bacteria in your gut before you get chemotherapy, so you don't have a risk of getting a resistant infection. So a lot of study going on, but not a lot of answers yet. Great question.
My question is a little bit less clinical in that, and to kind of piggyback on his question, is there targeted marketing and or stewardship for the geographic locations that you mentioned before where there's a higher, prescriptions in West Virginia, let's say?
Yeah, so it's a really good question. So are there targeted interventions by geography? In America, I would say the answer is no, right? Because we don't have a national health system. I guess the exception would be in health systems that cross multiple geographies. And I have colleagues who work in some of those, and they have some stewardship practices that cross different areas of geography. But it's actually very complicated in our country because of the fact that we don't even have one national surveillance. We have the CDC, but a lot of their data are actually modeled. So we don't have perfect surveillance data yet. And I think your point's a good one, but then you get into the realities. When we come back to that equity piece, you look at some of the states where the antibiotic prescription rates are the highest. They have the greatest proportion of uninsured individuals and people living in poverty. And in some of those cases, antibiotics are almost used as a proxy for other kinds of maneuvers that would be more beneficial. So very complicated situation.
So I'm wondering about like the overprescription of antibiotics largely contributing to the development of AMRs. So why is there this huge push then for the development of more antibiotics, I guess is my.
Yeah, great question. So if the problem's overprescription, why do we need more antibiotics? That's a very good question. So the problem is made worse by overprescription, but resistance happens at baseline, right? It happens in nature. And we have patients today who we can't treat. So I've had to send home a 42-year-old man with a heart pump that got infected. We couldn't treat it. So we had to send him home with hospice because we had nothing for him. So we have patients in whom we need options. So we will always need a renewable pipeline of antibiotics. We have to use them well. We have to not overuse them. We have to have good stewardship, but there will always be a need for antibiotics. One of the questions, quite honestly, that they're debating in Washington is how much is enough, right? If we're going to have these incentives, how many do we need per year or per decade, right? So in the UK, they're investing in 2 over 5 years, right? Right number. There's a lot of debate about that. Very good question. And this is one of the hard parts of this problem is that it's a yin and yang issue. You guys are great, by the way. Great questions.
I'm wondering about what kinds of alternative therapies might be available for patients in a hospital setting where right now antibiotics are being traditionally prescribed.
Great question. What about alternative therapies? Okay, so we didn't get into this. There are a number, right? You might have anybody heard about phage, bacteriophage? So really old therapy that hasn't really been that successful, but there've been a couple of life-saving examples. And there's work going on to make bacteriophage as a virus, basically, to kill the bacteria. There's a lot of work going on to see if we can kind of scale that up to something that's usable. The problems with it are that it's very specific. You have to have a phage for the particular bacteria a patient has. And you have to be able to make it fast enough to save their life. So very interesting, a lot of work going on in that. Vaccines. Vaccines are very important, right? The pneumococcal vaccination prevents a lot of bacterial infections. We don't think about that. The flu vaccination prevents a lot of bacterial infections. There are other vaccines that could be developed. I worked on a Staph aureus vaccine for MRSA years ago. There've been many, they've all failed, but if we could have a vaccine that would prevent MRSA and we could give it to people, say before they had heart surgery or before they went on dialysis, and that prevented them from getting a staph infection, that'd be life-saving. You think doing drug development's hard, vaccine development's even harder. And the return on the investment piece, the financial piece is very difficult, but important. The microbiome altering therapies we mentioned. Then there are other therapies that instead of killing the bacteria, work on the virulence of the bacteria. They make it less virulent, so it would cause a less severe infection. So there's investigation into those. What I would say is that in a broad stroke, those so-called non-traditional therapies are more risky. So they take people investing in them who have a higher risk tolerance and a longer kind of timeline to success. But it's important that we explore all of those because we don't have enough antibiotics. So great point. Okay.
One more?
One more?
question, anybody?
Okay.
Well, this was an amazing
Thank you.
first
you
lecture.
so
This class. Thank you so much, Dr. Boucher, and thank you to all of you for your level of inquiry and thoughtfulness and questions. Clearly, this is a class who is going to keep pushing all of us to think, which is a wonderful thing. So now, without much further ado, right? I'm looking to Mackenzie. We are going to welcome and introduce the Tufts University School of Medicine Main Track class of 2026.
Nicholas Baker, New Rochelle, New York.
Samantha Berry, Freeport, Maine. Jane Frances Branch, Orrington, Maine. Paula Karras, Saco, Maine. Aishwarya Chandrasekhar, Scarborough, Maine. Anna Deck, Brunswick, Maine. Abigail DeShippert, Cherryfield, Maine.
Owen Doan, South Portland, Maine.
Tanya Elkins, Morgantown, West Virginia.
Taylor Cho, welcome to Nashua, New Hampshire.
Eva Farkas, Pittston, Maine.
Veronica Gallant, Orono, Maine.
Porter Galvin, Harpswell, Maine.
Zachary A. George, Aspen, Colorado.
Grace Guile, Alfred, Maine. Lisa Goldman, St. Louis, Missouri. Jamie Gullickson, Denmark, Maine. Candy Picatello, Pasadena, Maine. Julia Hutchinson, Scarsdale, New York.
Alice Alcano, Rhode Island.
Abby Janet, Flint, Michigan. Caitlin Jodwin, Dora, Maine. Akira Jordan, Baltimore.
Maya Kilman, David Long, South Jersey.
Man.
Jeff Marcucci, Baltimore, New York.
Angela Martellos, Hudson, New Hampshire.
Tim McGargan, Charlotte, Vermont.
Morgan McKeown, Scarborough, Maine.
Cassandra McNichol, Rockland, Maine. Oliver, Portland, Maine. Emma Patterson, Denver, Colorado.
Justin Ramos, Scotty.
Sophie Smith, Bethesda, Maryland.
Jordan Zajac, North Granby, Connecticut.
There's your standing ovation. I've never seen that. So welcome. Do you have any more photos? We're good. Can we sit back down? Yep. So,
you can invite everyone to the reception.
Okay. All right. Everybody stay for a second, apparently. So you all know better than I do. So congratulations and welcome. I hope you feel the love, which apparently is here for you all. So I want to thank everybody who attended today, both in person and virtually. We miss those who can't be here, but we are thrilled that you're able to be here virtually. We thank Jeff Sanders for being here today and for welcoming you all. We thank Dean Boucher for her leadership and lecture. And I hope everyone here will join us for the reception afterwards. So welcome and have a great day as you lead into your first year and go to your preceptors meeting this afternoon. So thank you all and have a wonderful day.